Open. Good morning, one and all. Respected dignitaries, Assistant Director in Charge, officers, and all Ayurveda scholars assembled here. A warm welcome to you all to today's training session on skill development and research orientation for Ayurveda professionals, organized under Center of Excellence scheme awarded by Ministry of Ayush. To begin with, let us stand up for Dhanvantari Vandanam. Om Namami Dhanvantarim Adidevam Durasurai Vandida Padapadmam Loke Jararubhaya Mrityunasham Dhadaramisham Vividhaushadina. Thank you all. Please be seated. Now, I would like to invite Dr. Sulochana Bhatt ma'am, in charge of CARI and Principal Investigator of Center of Excellence for Research and Clinical Services in Magneha, to deliver the welcome speech. Over to you, ma'am. Namaskara and good morning to all of you. I am really feeling very happy to welcome you all to the Skill Development and Research Orientation Program organized by Central Ayurveda Research Institute today. From 2021 onwards, ever since the Center of Excellence scheme was awarded to Central Ayurveda Research Institute, we have been organizing this kind of orientation program for Ayurveda professional and students every month with our in-house resource persons. But this time we are very fortunate to have three eminent scholars who are renowned endocrinologists as our speakers. A Center of Excellence scheme was proposed in 2017. At the time, Dr. Shekhar, who is also one of the speakers today, had helped us in bringing a definite shape to the program. Later on, 2021, this was awarded, and by God's grace, Dr. Shrikanta as our guru and mentor. And whatever progress we have made today in this particular scheme is thanks to Dr. Shrikanta. Samatvam, his institution, also has a Center of Excellence scheme awarded by Ministry of Ayush. IISc Bangalore, and CARI is also one of the collaborators in the program. And you will be very happy to know that Dr. Srikanta's contribution is more than any Ayurveda professionals done so far in this field. For instance, he has enrolled 320 patients in an Ayurveda clinical trial, and the intervention period is 2 years. You all know that nobody has done it so far. 2 years of intervention period and 320 patients. And the parameters are Sir telling you about it later on. And Dr. Kavita is also part of our team in Center of Excellence, maybe CARI or Samatvam IISc. And she is an authority in research methodology also. So when this was planned in 2017, as I told you, Dr. Shekhar was there with us. He was Later, he retired as director, Karnataka Institute of Endocrinology, and moved to Mysore. Still, we have great association with him also. Center of Excellence scheme is our scheme is getting over in March officially this March. We are going to extend it for another year in a small scale. We have. I'm very happy to tell you that, inform you all that we have achieved set targets. For example, infrastructure upgradation, obtaining NABH, NABL certification. We also have ISO by Bureau of Indian Standards. We have upgraded our laboratory, clinical laboratory, drug standardization laboratory, our botanical garden we have done, and that's also shown in terms of the research studies that we have today. We have 25 research projects in collaboration with different other institutions like IISc, CFTRI, Mysore, maybe this the Department of Ayush. So several studies we have undertaken. Patient footfall has increased 4 times or 5 times in a period of 4 years. So that is commendable. Achievement is commendable. Without taking much time, because we have renowned experts later on. Welcome you all. I particularly welcome dear students from Sri Sri Ayurveda College and respected faculty members, my own Carrie family, and everyone who has joined online today. Hope we all time let us enjoy this and take the benefit of this great learning opportunity. Thank you and welcome you once again.
Thank you, ma'am. A small introduction about Dr. Shrikanta sir. He is a highly distinguished Indian endocrinologist and researcher, currently serving as a medical director and senior consultant at Samatvam Endocrinology Center in Bengaluru. He is recognized for his extensive work in diabetes pathogenesis and his commitment to providing care to underprivileged communities. He has held significant leadership roles in India, including medical director at Samatvam and Gnana Sanjeevani Medical Center since 1993, a former departmental head positions at SGPGI, Lucknow, and AIMS, New Delhi. He also serves as an honorary senior consultant and faculty at NIMHANS, Bengaluru. His main research focus is on type 1 diabetes pathogenesis. As an academic mentor, he has trained over thousands of clinicians, scientists, and health professionals across the world who are serving across the world too. How much ever we say about this person is less because his achievements are more than books. So I welcome him directly so that through his presentation, you will come to know who he is. Sir, over to you, sir.
It is not slow. Very slow, sir.
ಇದರಿಂದಾನೆ ಪ್ಲೇ ಮಾಡ್ಬೋದು
ಡೈರೆಕ್ಟ್ ಎಂಟ್ರಿ ಪ್ಲೇ
ಆಗುತ್ತಲ್ಲ. ಕಾರಿ ಹೇಳ್ತೀನಿ ಯಾವುದು ಅಂತ. ಇಳಿಸ್ಕೊಡು ಲೇಟೆಸ್ಟ್ 1122 ಫೈನಲ್ ಮೈಕ್ರೋ ಇದಾಕು.
Listen, sir.
ಅಲ್ಲಿ ಹೇಳ್ತೀನಿ. ಇದು ಹಾಕು.
Listen, sir.
ಎಲ್ಲ ಆಗುತ್ತೆ ಬಿಡು, ಅಲ್ಲಿ ಮಾಡು. ಬೆಳಿಗ್ಗೆ ಆಗುತ್ತೆ. ನಾನು ಮಾಡ್ತೀನಿ.
Wait, sir. I will share this.
ಇದು ಮಾಡಿ, ಸ್ಪಾಟ್ ಫುಲ್ ಅಡ್ಜಸ್ಟ್ ವ್ಯೂ ಮಾಡು. ಅಡ್ಜಸ್ಟ್ ವ್ಯೂ ಮಾಡಬೇಕು. ಕ್ಲೀನ್ ಮಾಡೋಕ್ಕಿಂತ ಮುಂಚೆ ಫಸ್ಟ್ ಅಡ್ಜಸ್ಟ್ ವ್ಯೂ ಮಾಡಬೇಕು, ಎನ್ಲಾರ್ಜ್ ಆಗುತ್ತೆ. ಹೈಡ್ ಮಾಡ್ಬೋದು. ಅಡ್ಜಸ್ಟ್ ವ್ಯೂನಲ್ಲಿ ಪಿಕ್ಚರ್ ತೆಗೆದ್ಬಿಡು, ಬೇಡ ಮಾಡಿ ಇದನ್ನ ಇದು ಮಾಡ್ತಾ ಇಲ್ಲಿ ಕೂತ್ಕೊಳ್ಳಿ.
I'll do, sir.
ಇಲ್ಲಿ ಮಾಡ್ತಾರೆ, ಇಲ್ಲಿ 3 ಡಾಟ್
It will come.
ಬಂತು.
Yeah.
ಓಕೆ, ಬರಲ್ಲ. ಅಮ್ಮ ಶ್ರೀ ಹರಿ ಓಂ ಶ್ರೀ ಸದಾಶಿವ ಸಮಾರಂಭಾಂ ಶ್ರೀ ಶಂಕರಾಚಾರ್ಯ ಮಧ್ಯಮಾಂ ಅಸ್ಮದಾಚಾರ್ಯ ಪರ್ಯಂತಂ ವಂದೇ ಗುರು ಪರಂಪರಾಂ. Namaste. It is wonderful to see all of you young ones here. I think I'm the oldest man here. Come. This is my boss. Okay. I retired from our trust more than 15 years ago. Now I take care of patients, do some research and do some teaching. So she took over as the trustee and the medical director. Her name is Kavita Muniraj. Very, very bright. She is the American College of Endocrinology, trained by us. Before, she was in Quintiles, one of the world's largest contract research in Bangalore. I think she had about 250 doctors working there. Got tired of corporate world, joined our trust, and she reads it. She has a son, Anirudh, who is 10 times smarter than her. He's a doctor. Now he's going to become a physician. He passed from the medical college. Now he's joining his MD. To me, when I introduce people, she takes care of my health and everybody's health. I make a patient or do something, she picks 10 mistakes in me. So that is the advantage. And then all the time she is correct. I just want to narrate you one question to see young faces. It will be make us. I was in Boston at that time. I was a faculty at Harvard. I used to live in a small apartment next to the hospital, and there was a janitor. Janitor is the person who cleans the plumbing. He was illiterate. Was there 5-6 years. He knew I'm a doctor walking every day to the hospital and the research center. One day he stopped. He said, "Hey, doc, I have $10 in my pocket. I give to somebody $5, I lose it. Tell me 2 things in this world. If I give to someone, it does not decrease." It's the second one.
Yeah, somebody told it.
Yeah, correct. Okay. There's a guy called Trump. We should tell him that, and not to create war. So I told him, I don't know, you tell me. He told knowledge and love. If you give, it augments. So here we have come to you not to preach, but to learn from you. The more you give. Madam has given us the topic of diabetes management from basics to practice. From last 3-4 years, Madam knows it. She prepared like a school child, and like you do homework and I record my talk. It works out very well. If you talk extempore, you miss some points. This is what I learned from my teachers. Tomorrow when you teach, your slides will be good quality. It should not be jumbled. You have to take people from top to bottom and side. And you should be in a rapt attention. I was telling Kavita, you are in a devotional bhajan or thing, you immerse yourself. The next 20, 30, 40 minutes, you would have forgotten everything. So this works out well. it has two parts. It is from the updated ADA, American Diabetes Society, with additional points. She will coordinate the first part up to section 8. And she'll be here, and you listen, and we take a break at 8, answer the questions. Then second part, I will take over and do it related to pharmacotherapy. About less than a year ago, I met Vaidya Rajesh Kotecha, who is the secretary of Ayush, all through this angel sitting here. And I told him, last 5-10 years, he is teaching me a lot of Ayurveda. Now everybody is worried. What happened to my MBBS? I can talk Nishakadakadi Kataya, Bhumandi Nikchurna, all those things. Varadi, Mustadi, Daru, Ridra, Bilva, all those things. And we are using it. We are, with her blessing, one of the largest. I'll tell you in the end. She will. Okay. After the two parts, I think you are young, you have energy. I have some surprise for you. It is I will take another 20 minutes apart from this to tell you something, the miracle done by Sulochana to all of us. I didn't know her. God brought us together. Dr. Kishore of Nimans, he introduced us, and she has done a lot of miracles. Yeah. The IASC Center of Excellence is all hers. Her blessings, she continues. And so that is a surprise for you. And I enjoy, relax, put on your questions. It is slightly packed. See, to cover something like diabetes is tough. So it's concentrated. Right now, we have 3 Ayurveda full-time physicians working with us through the projects. Again, they're extremely bright and meticulous. And you're most welcome. This center is a center of excellence in Ayurveda for diabetes. The other one, which she blessed us, was Center for Excellence in Ayurveda at Indian Institute of Science. Professor Namakant Bhatt is the principal investigator. Samatvam and Kari are associated institutions. The clinical trial takes place in Samatvam, JP Nagar. Anybody, most welcome. She can share our email ID, and you will see the India's first integrated endocrinology diabetes clinic. 2 rooms, 10 rooms. The endocrinologist sits next to the Ayurveda, open room with a passage, no barrier. Patients sees both. They see it is an integrated clinic, and the patients are very happy. We have more than about 320 patients there. Lot more work. One last point, which I'll tell you in the end. I'll talk to you a little more detail about 2 drugs. I don't call it 2 drugs. Okay. Before this, I want to ask you, this allopathy, Ayurveda, modern medicine. Anybody can tell me how the term allopathy came? Anybody in this group know? Ayurveda, everybody knows. How the word? Nobody knows. It was coined by the homeopaths. They told that we are, and rest of it is, allo means others. Like a third world, na? Europe is first world, America is second world, we are all third world. So allopathy means we are all out. Allo means different. No, there is no better term to describe than Ayurveda. What is Ayurveda? What I understand is knowledge and health. Okay, science of health, whatever it is. Veda and Ayur. Everything is, every doctor practices Ayurveda only. The barrier between is totally bogus. And it is like religion. I don't care for religion. It is spirituality. Human spirit is everything. It is science. Science is called truth. So there is no difference. The medicine called metformin came from French lilac, a plant. Old drug, the foundation. The second medicine, which is $1 billion, called gliflozin, SGLT2 inhibitor. It is from apple bark. God was not stupid to create only 2 plant-based medicine. There are millions of them. Our ancestors have used it successfully. We just have to rediscover it. We are not doing anything. There is a lot of scope, and I'm especially happy that the Ministry of Ayush is separate. It should get more recognition. And Madam is doing the research seminar. You will get a lot of wealth available, lot more to go. We don't have to go by the Western chemical approach. That last part I will give you. I will take little extra 20 minutes. Now, Kavita, you introduce and they will play this.
Good morning, everyone. I think Sir said it all. So we'll start the session and happy learning.
Mom. Be there only. You have to do the point.
Only there, though.
Trust me. ಪರವಾಗಿಲ್ಲ ಇದ್ರ ಮೇಲೆ ಬರಲ್ಲ it won't come on the screen. It won't come on the it only comes on the it won't come on the TV screen. Doesn't matter. Okay. Turn after the 8 chapters, this is the no, one second. No, this is the one. I was thinking the title I changed. I just changed the title. Start.
Respected mentors, colleagues and friends. Once again, many thanks for the continued learning opportunities. The title of my presentation is Diabetes Management Update 2024 Therapy and Prevention. Our sincere pronouns to the Gurudevs and colleagues of Central Ayurveda Research Institute, Bangalore, for inspiring us and guiding us on the path of diabetes and metabolic disorders management through the Ayurveda science and Ayurveda therapy. First, let us have a look at some of the selected aspects of the Standards of Care in Diabetes 2024 as enunciated by the American Diabetes Association. Section 2, Diagnosis and Classification of Diabetes. The standard diagnostic tests for diabetes include HbA1c, fasting plasma glucose, oral glucose tolerance test, and even random glucose value with classic hyperglycemia symptoms or hyperglycemic crisis. There is insufficient evidence to support the use of continuous glucose monitoring for screening or diagnosing prediabetes or diabetes. In the absence of unequivocal hyperglycemia, example, hyperglycemic crisis, diagnosis of type 2 diabetes requires confirmatory testing, which can be a different test on the same day or the same test on a different day. Marked discordance between HbA1c and repeated blood glucose measurements should raise the possibility of a problem or interference with either test, HbA1c or blood glucose measurement. Classification of diabetes type is not always straightforward at presentation, and misdiagnosis is common. The different types of diabetes are summarized in this slide. Type 1 diabetes due to idiopathic or autoimmune beta cell destruction. Type 2 diabetes due to degenerative non-autoimmune progressive loss of adequate B cell insulin secretion, frequently on the background of insulin resistance and metabolic syndrome. Diabetes from other causes like monogenic diabetes syndromes, diseases of the exocrine pancreas, and drug or chemical induced diabetes and gestational diabetes mellitus, GDM, detected at 24 to 28 weeks of gestation in individuals without previously identified diabetes or high risk glucose metabolism. Today, in our discussion, we will restrict ourselves to type 2 diabetes. Regarding type 2 diabetes, several unmet needs exist, and these are related to the following domains: pathogenesis pathways, earliest diagnosis, efficient monitoring, safer therapies, better therapies, and even most importantly, preventive approaches. All of us know that insulin resistance and beta cell dysfunction are the core defects of type 2 diabetes, both dependent on genetic susceptibility and environmental factors, including obesity and unhealthy lifestyle. Insulin resistance refers to subnormal biological response to normal insulin concentrations. Beta cell dysfunction refers to reduced ability of the pancreatic islet beta cells to make insulin in response to hyperglycemia. This slide illustrates the multiple loci of type 2 diabetes pathogenesis at the level of the pancreas. This includes decreased insulin secretion and increased glucagon secretion. Then at the intestines, decreased incretin effect. In the fat cells, increased lipolysis. In the kidneys, increased glucose reabsorption. In the muscle, decreased glucose. In the brain, neurotransmitter dysfunction. And in the liver, increased hepatic glucose production. Section 3: Prevention or delay of diabetes and associated comorbidities. Diet and physical activity recommendations for adults at risk for type 2 diabetes to follow a healthy eating pattern consisting of emphasizing whole grains, legumes, nuts, fruits, and vegetables, and minimizing refined and processed foods. A variety of healthy eating patterns that have been described include Mediterranean style, low carbohydrate, vegetarian or plant based dash dietary approaches to stop hypertension. Next, getting regular physical activity equal to or greater than 150 minutes per week of moderate intensity physical activity, such as brisk walking, may include resistance or strength training, break up prolonged sedentary time. The next important question: what medications can be prescribed to adults to prevent type 2 diabetes? The US Food and Drug Administration has not approved any drugs for diabetes prevention till date. However, metformin has the strongest evidence base for diabetes prevention. Now, who should be considered for metformin therapy to prevent type 2 diabetes? They include adults aged 25 to 59 years with a BMI greater than 35 kilogram per meter square, individuals with higher fasting plasma glucose, example, greater than 110 milligram per deciliter, those with higher A1C, that is A1C greater than 6%, and individuals with a history of gestation mellitus. Are there any parameters that should be monitored in people on metformin therapy? Yes. B12 should be measured periodically, especially in those with anemia or peripheral neuropathy. The other more prudent and pragmatic approach is to give supplementation with vitamin B12 orally for each and every person on metformin therapy. That is what we practice in our clinics every day, as opposed to routinely monitoring vitamin B12. Section 4, comprehensive medical evaluation and assessment of comorbidities. Now, let us look at few of the comorbidities associated with prediabetes and diabetes. Let us begin with NAFLD, or non-alcoholic fatty liver disease, which has been recently renamed as MASLD, metabolic syndrome associated steatotic liver disease. I would rather just call this entity as merely steatotic liver disease, SLD, associated with insulin resistance. Now, how prevalent is non-alcoholic fatty liver disease? Who should be screened for it, and how in our clinical practice? Regarding prevalence, it has been stated that approximately 70% of people with type 2 diabetes have NAFLD. The screening goals include to identify individuals at risk for complication from NASH, non-alcoholic steatohepatitis, such as cirrhosis and hepatocellular carcinoma, and to prevent death from liver disease. The high-risk individuals where we have to focus include people with central obesity and cardiometabolic risk or insulin resistance, individuals greater than 50 years of age, those with persistent high plasma aminotransferase levels, AST, ALT greater than 30 units per liter for greater than 6 months. What are the screening tools? The easiest and the simplest is to calculate what is known as the fibrosis 4 or FIB4 index score, which is based on 4 parameters: the person's age, ALT and AST levels, and platelet count. Screen with the FIB4 index even if liver enzymes are normal. A FIB4 index calculation tool is available online. This slide summarizes the proposed algorithm for risk stratification in individuals with NAFLD or NASH. As mentioned, this begins with non-invasive testing for fibrosis through FIB4. In low-risk individuals, repeat FIB4 in 2 to 3 years. In intermediate risk and high risk subject, it has been recommended to conduct an additional test known as elastography, vibration controlled transient electrography, which can be done by few methods, or by ELF blood test. ELF stands for enhanced liver fibrosis. If this elastography or ELF blood test shows low risk, repeat the same in 2 to 3 years. If these tests show high risk, it merits reference to a gastroenterologist or a hepatologist. Now, few words about the challenges in the management of NAFLD, MASLD, or steatotic liver disease associated with insulin resistance. The most important one is weight loss with intensive lifestyle therapy as appropriate is recommended. We will not discuss about metabolic surgery today. Glucagon receptor peptide 1, GLP-1 receptor agonist, or the preferred agents for treatment of hyperglycemia in adults with type 2 diabetes and NASH, unless decompensated cirrhosis is present. It is a very good novel class of pharmacologic agents, GLP-1, which is derived from the nature. I would not like to talk about the drug pioglitazone because I don't prescribe it and it is truly a problematic drug. Next, people with type 2 diabetes and decompensated cirrhosis from NASH require treatment with insulin. Regarding statin therapy and liver dysfunction, statin therapy is safe in the setting of NAFLD, but we have to use with caution and close monitoring in people with decompensated cirrhosis. Section 5. Facilitating positive health behaviors and well-being to improve health outcomes. Dear colleagues, all of us know that in every aspect of human endeavor, including human health and happiness, body, mind, and spirit need equal attention. That is the foundation principles of the ancient Indian yoga and Sanatana Dharma. Building positive healthcare behaviors and maintaining psychological well-being are foundational for achieving diabetes management goals and maximizing the quality of life. And each one of you are practicing it on a daily basis. The essential task to help people with diabetes achieve their goals are listed here. First, diabetes education. Reference to professional diabetes self-management, education and support groups, DSMES. Reference to professional medical nutrition therapy, MNT. Counseling on routine physical activity, counseling on and support of cessation of tobacco products, counseling on health behaviors, support and reference to behavior health professionals for psychosocial care. Medicines, insulin, love and care from family and professionals will be foundational for healthcare, including diabetes care. Again, as you are all familiar, the key nutrition principles including in our meal planning, non-starchy vegetables, whole grains, nuts and seeds, low-fat dietary products, whole fruits and legumes, and to minimize meat, sugar, sweetened beverages, sweets, refined grains, and ultra-processed foods. Data do not support a specific distribution of macronutrients. Patients with diabetes may choose from a variety of healthy eating patterns to fit their needs and preferences. Printed diet charts handed over to the patients, again, I personally feel are impractical and meaningless. Few words about a popular term in diabetes medicine, that is diabetes distress. Diabetes distress is defined as the emotional response to living with diabetes and managing its daily challenges. It can include feelings of frustration, sadness, guilt, or worry. The ongoing demands of diabetes care, self-care, and the possibility or reality of disease progression are directly linked to reported diabetes distress. Some people consider as the sword of Damocles. High levels of distress significantly affect medication taking behaviors and are linked to higher A1C, lower self-efficacy, and less optimal eating and exercise behaviors. We have data, particularly in type 1 diabetes children and youngsters, that not only physiological replacement of insulin, but love and care from the family, from the health professional, from the society are equal importance. HbA1c and happiness are both dependent on not only medical care but love and support. Next, section 6, glycemic goals and hypoglycemia. Regarding assessment of glycemic status, all of you are familiar with the traditional hemoglobin A1C, HbA1c measurement. However, the new kid on the block is continuous glucose monitoring or CGM, where we use appropriate metrics. These are called time in range TIR and the glucose management indicator GMI. When to assess, how frequently? In those meeting treatment goals, at least twice a year. For individuals not meeting treatment goals with frequent or severe hypo or hyperglycemia, change in health status, or growth and development in youth, we can test more frequently, at least quarterly or more frequently as appropriate clinically. Little additional information on continuous glucose monitoring or CGM. As of today, CGM has become the standard of care for each and every patient with type 1 diabetes in the affluent West and also in certain type 2 diabetes patients. However, in India, the utility of this is minimal because of economic reasons. It may cost up to 10,000 rupees per month if you are going to do 365 days CGM. Now, this shows some information of the glucose assessment via CGM and what is known as the aggregated glucose profile AGP report. Ensure sufficient data for analysis. The CGM should be active for at least 70% of the time over 14 days. In India, the only available CGM is known as Abbott Libre, and it is a small patch which gets affixed to your arm and which measures interstitial blood glucose and transfers the data to an electronic device to your mobile phone. We have to review the CGM report and discuss individual daily self-management routine. We have to ask our patient to identify and explain what are the variations they observe in the report. I will show you a few examples. There are what are known as CGM metrics. They include TIR, time in range, percentage of readings and time with glucose 7 to 180 milligram per deciliter. Time below range or TBR, percent of readings and time with glucose less than 70 milligram per deciliter. Time above range TAR, percentage of readings and time above 250 milligram per deciliter. Other glucose metrics are mean glucose, a term known as GMI, glucose management indicator, which is a rough estimate of A1C, and glycemic variability, which is expressed as a percent coefficient of variation. The target is to get less than 36%. You get a graph bar diagram like this, indicating the green time in range, and then time below range and time above the range. On the right-hand part of this slide are shown the graphic representation of the 24-hour glucose profiles, ambulatory glucose profile. And the bottom is the profiles and variations on each day for about 14 days. The two horizontal lines here indicate the target range 70 to 140, and the one below is the time below range, one above is the time above range. This is the mean of the 14 days, and one below is the pattern for each individual day. So when you sit with the patient, you have to identify any hypoglycemia first and then look into hyperglycemia patterns. We review the time spent in each of these patterns on the overall profile and the daily graph. We have to discuss the identified patterns and ask individuals to reflect on what he or she thinks are the potential causes and possible for this high sugar. On the day he had very low sugar, did he miss his night dinner or snack? On the day when he had unusually high sugar, was it a day of his friend's wedding? If you use CGM metrics to assess glycemia, the goals for non-pregnant adults or those with frailty will vary. Set glycemic goals based on general guidelines. A shared decision making and an action plan are a must. All of you must be familiar when you look at the HB report from some of the labs. They express not only HbA1c, they express what is known as EAG or estimated average glucose. So this shows the A1c and the corresponding estimated average glucose, which you can use it in patient education and counseling. This is a famous and informative slide from American Diabetes Association regarding the approach to individualize glycemic targets. Here is A1c of 7. In some patients, you might be able to achieve a more stringent A1c of say 6.5. In other patients, it may be good to be less stringent and try to target an A1c of 7.5 to 8. Now let us look at what are the situations when you want to achieve more stringent A1c. Patient disease features, potentially associated with hypoglycemia or other drug-related adverse events when they are low. Disease duration, newly diagnosed. Life expectancy, long. Young individuals. Important comorbidities, absent. Established vascular complications, absent. Individual needs and preference. Highly motivated. Excellent self-care capabilities. Resources and support system. Money and family support readily available. Under these conditions, try to target an A1c of 6.5. On the opposite condition, you may think of 7.5 or 8. Section 7, Diabetes Technology. What is this very fashionable term nowadays known as diabetes technology? This is supposed to include insulin pumps, also called subcutaneous insulin infusion, CSII systems. They are insulin delivery devices that are worn on the body. Second, connected insulin pen and pen caps or insulin delivery pens are related these devices that can record and or send insulin dose data and may also calculate doses. Third, continuous glucose monitoring CGM systems and glucose meters are devices to monitor glucose levels. The most advanced is what is known as artificial pancreas. Better term is automated insulin delivery, AID systems. They connect a CGM system with an insulin pump which talk to each other with a control algorithm on your mobile phone to deliver insulin automatically. Theoretically, even diabetes self-management support software, the various apps and online platforms that are intended to treat a medical or psychological condition or assist with data management or lifestyle modification can also be included in the term diabetes technology. Section 8, obesity and weight management for the prevention and treatment of type 2 diabetes. Regarding obesity, after 4+ decades in clinical practice, in simple terms, I consider obesity a most horrible disease, most difficult to treat for our patients and for ourselves. A holistic approach to obesity management is essential, encompassing nutrition counseling, regular exercise, behavioral strategies, and diabetes self-management education to ensure effective and sustainable results. Let us just look at the theory, data, and the results of major RCTs. Management of overweight and obesity. In people with type 2 diabetes and overweight or obesity, weight management should represent a primary goal of treatment, along with glycemic management. Don't focus on sugar alone. Weight management is crucially important because it has been shown by multiple studies that it delays progression from pre-diabetes to type 2 diabetes, is highly beneficial in treating type 2 diabetes, improves glycemia and reduces the need for glucose-lowering medications, reduces cardiovascular factors, lowering long-term cardiovascular and mortality risk, reduces other obesity-related health risks. I still remember the 3-decade-old data which I keep talking to patients. Every 15 minutes of brisk walking every day increases lifespan by 5 years. 30 minutes walking per day, 10 years. 45 minutes walking per day, 15 years. And 20 minutes and 60 minutes walking per day can add possibly 20 more years to your lives. I tell them this is much more than what a cardiothoracic surgeon with his bypass and angioplastics and nephrologist with their hemodialysis and transplant can achieve. But this walk should begin at high school and earlier, not after retirement. When addressing weight management, use person-centered, non-judgmental, first-person language. It's a person with diabetes rather than diabetic person with obesity rather than obese person. All about stigma. Calculate BMI and perform measures of body fat distribution, waist circumference, waist to hip ratio, waist to height ratio. Monitor obesity-related parameters at least annually to guide treatment decisions. Focus both on sugar and fat. That is the listed here are the international recommendations for person-centered treatment options for overweight and obesity in type 2 diabetes. For BMI between 25 to 26.9, 27.9 to 29.9, equal to or greater than 30. Intensive behavior counseling, obesity pharmacotherapy, metabolic surgery. I do not want to discuss with metabolic surgery today because of certain personal opinions regarding the use and the misuse of this approach, especially in our country. Regarding pharmacotherapy for obesity, another challenge, I've just listed few medications for you. Short-term treatment, 12 weeks, phentermine, which is a sympathomimetic amide anorectic. Long-term treatment, 52 to 56 weeks. Orlistat, ligase, and antidepressant combination. I have no experience in any one of them. The ones which are most popular, for which the maximum experience, which I love because they are physiological, they are naturopathy, they are Ayurveda, they are made by Lord Almighty. These are the group of drugs called glucagon-like peptide 1 agonist, GLP-1 agonist. I recommend all students to read about them. They are called incretins, single compounds, they are peptides. Now you have tricretins or dual cretins, which are a combination of two peptides, and you also have triple cretins. These have become billion-dollar blockbuster drugs and widely used even in this country. But the sad thing is the cost, which prohibits their use. I do hope one day these are available at very affordable cost in the generally shops of Honorable Shri Narendra Modi ji. The GLP-1 agonists in use in would cost about 10,000 rupees per month. Now the Indian version, the cost has come down to about 4,000. Tirzepatide is a dual cretin, it's a dual glucose dependent insulinotropic polypeptide and glucagon-like peptide 1 receptor agonist. It is a unimolecular dual agonist for both GIP and GLP-1. This simple slide summarizes the relative weight loss efficacy of various glucose-lowering medications. These are glucose-lowering medications which can have additional properties of weight loss. The most efficient, very high efficacy are tirzepatide, the twin cretin, and semaglutide. The high efficacy are dulaglutide and liraglutide. The intermediate efficacy are few other GLP-1 agonists plus SGLT2 inhibitors like the gliflozins. The drugs like DPP-4 inhibitors are considered weight neutral. I don't know why metformin has been listed here, but metformin also contributes to weight reduction to a certain extent. Section 9, pharmacologic approaches to glycemic treatment.
Do you all have any questions? Any questions in this 1 to 8 section? If you have any doubt, is it clear? Very clear.
No, you are not asking.
Any questions? Yeah.
This working they have from high school we have to start. And it is not useful.
Before?
From high this working is
Yeah,
recommended from high school. So after retirement there is no use of this working.
No, it is not that after retirement it is not useful. It is part of your lifestyle. You have to start as early as your high school. That's what it meant. It says. Most of the people, they are very busy doing their work. They don't have time for walking, exercise. That's what we see from all our patients. We do not have time. We don't have time for. Our first thing is lifestyle management. We tell them at least half an hour a day work. So they are not able to do that also. So that we have to counsel a lot when it comes to lifestyle. Giving drugs is very easy. We can give them and ask them to take. Asking them to do diet changes and then asking them to walk and to incorporate some lifestyle changes, that is very difficult. So it is not that you should not start after 60. The earlier the better. You can do any time.
Excuse me, ma'am. Can you explain more regarding
Yeah, I can do.
Can you explain more regarding the diabetes technology? The insulin pumps, as well as the PGM and glucose meters.
So CGM is it's like a patch. What instead of you checking every time with the glucometer, so you put a patch. And currently, what is available is Abbott one. So that stays for 14 days. And with that, you can get 24-hour reading for 14 days. So after 14 days, you have to change. So what happens? You saw the sample, right? So for every CGM, we have time in range, time above range, and time below range. If the person is in 70%, at least 70% in time in range, that means he has good glucose control. We are aiming at 70%. He can have more also, but at least 70% is the time in range. So time in range, how do you fix? You can keep it 70 to 180. That is what usually we give, 70 to 180. Below 70, it is time below range, and above 180 onwards, we'll call it as time above range. And at that time, we will look into the patterns. Why it is gone low? If it is hypoglycemia in the night or when it is, and then why is it going high immediately after food or after exercise or whatever? What is the reasons? And then we ask them also to write down there. If you've gone to a party, I went to a party. If I missed insulin, if I missed eating, write down there. So that helps in a lot of managing the patient and not adding additional drugs. So we can manage them with a good lifestyle. So that's about safety.
What about insulin pens, ma'am?
Insulin pen
And cap pen?
insulin pen, you have insulin pens now, which is usually available everywhere. Or insulin pens you have not seen.
Pen caps?
That insulin pen, that and sometimes there will be like the algorithm, it will display your readings. It will display your readings also in the pen. If I have anything to add.
Many of you have seen insulin pen. Insulin pens are just glorified syringes. The insulin pen cap are not popular in India. Insulin pen just deliver 8 unit, 10 unit, 20 units. The insulin pen cap has a software on its tab. And when you load it 10 units, it is high. So each try to take again by mistake, you have already taken. See, if you are in this field about 45 years, same stories. I'll tell you one true story about this. I have one very young, very bright. All the profession in the Brahman. Okay. He's a very bright man. He is in fact the right hand man of Wasim Premji. He and his wife had gone. He is a very religious, spiritual man, very disciplined. He had gone with his family to London for a vacation. And he's on bomb. They were leaving London. That morning in the hotel, they had breakfast, all confusion, 2 children back. He was taking the flight from London to Bangalore by Frankfurt. So in the breakfast, he has taken, he promptly has given his bonus, landed in Frankfurt, and then the second flight took from Frankfurt to Bangalore. The flight was on about 30. And in the air, he walked and he became unconscious and he fell down on the floor. He is very knowledgeable. He was a something went wrong. It was bigger hypoglycemia. So the wife, the pilot, they all panicked they took permission to land in Turkey for emergency medical care. It was about to land. He became conscious, and the pilot told no need to stop. It came back up and landed. Why did this happen? No. If in the confusion in the morning he had taken his bolus, forgot into a second bolus. He had doubled it. Children, the confusion on the last day you back out, etc. So this happens. And sometimes they miss the meal bolus. So it is applied with some software to remind you. Now everything I don't know. It will tell you what happened. Hey, you have at 12 o'clock, you have not taken reminder. It's just one more software. That is the I've not seen any Indian. I don't know that it's available. They use the pets. And two questions. How many of you have seen CGM or one of your relatives is using? Okay, you have seen. Oh, a lot of you. Lift your hand if you have seen CGM. Not bad. What is the name of the CGM you are familiar with? Is this the standard? Tell me what you know about CGM. Who used the set? Type 1. He's not suffering with type 1, yes. A deficiency there. They suffer from smoking and drinking. And laziness, not that person. Yeah, he doesn't know he suffers, you tell me. How does it work, all that? Good. It's okay, learn about it. It's factored now. Every type 1, if you have money, you simply see the glucose watch. That's all about it. You can adjust. And it doesn't measure blood glucose, it measures the interstitial level glucose. There is a 20-minute line. It is the standard of care. Type 2 can use it once in 3 months, it depends upon it. Okay, but type 1 it's must. A few more questions. Yeah. Last class we brought 2 young people who are using the today next time. You are most welcome. You can share the clinic address. Walk anytime. It's somewhere in JP Nagar. You can come. You will get your coffee. You will get your vegetarian sandwiches. You just have to walk in, sit through. Type 1 now. Okay. For type 1, it's insulin. Insulin is Ayurveda, made by man above, and this one can play an adjunctive role. Without it, they won't survive for a day. Okay.
Electrograph using clinical practice.
Excuse me.
Electrograph, Electrograph,
Using clinical practice, how can we assess the risk of the patients?
Yeah, it gives, there are different ways of doing the fibrosis scale. It has become fashion. One, the clinic through the portable machine. What I know is the ultrasound electrography is the best. You can measure by ultrasound, CT, MRI, etc. The most, it's still like it's about 3,000 rupees. Okay.
they measure the stiffness of
Stiffness.
and then they will give you a metabolic score, like F1, F2, F3, which is the moderate fibrosis, it is the mild, and when you have to really refer to a pathologist, when you should start giving a pharmacotherapy which is more helpful in this kind of conditions, that will give us score.
It's called metabolic score. There are 2 indices. You will get a chart. As we progress F1, F2, F3, F4, 3, 4 and all, it's universal. It is just to monitor. At 2 and all, you can reverse it back. Okay, now there is a new term, MASLD. It was NAFLD, non-alcoholic fatty disease. Now pundits have made it metabolic syndrome associated, metabolic dysfunction associated steatotic liver disease. Fat is steatotic. It's basically it's a steatotic liver disease. Any question? Okay.
It goes always the latest between 10 to 11. What's the best way to manage it? Because my mother, she's a type 2 diabetic since she was 34 years. And now she's almost 51 years. And since then, she's having diabetes. And it ranges, the HbA levels are always in between 90 and 100. But the HbA1c is never going down. It's always ranging between 10.8 to 11.
FPS is less than 100.
Yeah.
What is the most reliable?
After food, it might be around 120, 130, 150 range.
It's a very good question. So my boss will answer.
See, you will have something called hemoglobin variant. You have to see whether your mom has anemia, any other kind of interference. If you're doing the same lab, but you're doing a different lab, all those. The most common is iron deficiency. So you have to look whether she has anemia because it always depends upon the turnover of your lab. So 3 months, 120 days is the normal lifetime. If there is anything like less turnover or more turnover, then that will cause the increase or decrease your agency. Also, you have like sickle cell anemia and all other kind of hemoglobinopathies. Also, you will not have a fixed, correct agencies will not be able to get it. In case of sometimes in pregnancies also, because of plasma dilution, you may not get a correct agency there. So in those cases, you follow your blood glucose levels. FBS below 100 and after food 120 is very good. But you find out why the A1C is high, whether she has any other condition.
She has a she also cardiovascular patient. She has been studied, like 2 stents have been put, angioplasty has been done. So does that have an impact on
What age?
When I explain to you, what I understand is your mother fasting glucose is around 90, 100, less than 100. Is less than 200, it's around 180.
Yeah.
Okay. You saw the chart. Okay. It's called, excuse me, you can feel free to share the video with all of them. Okay. You upload on your website and share the link and say. Here's the chart. Okay. How many of you have not used ChatGPT? Here, who have not used it? Everybody is here. How many have used Perplexity? Okay. Who is the founder of Perplexity? Anybody? Well, now it's going down because everybody is giving money to an Indian. Okay. Who uses Gemini? Have anyone of you heard what is known as Claude? Kind of. Okay. AI is good, AI is bad. You have to be very careful. Okay. I made reviews extensively. When you come to the clinic, you see. There's a big man in Harvard Business School, he has made it. Humans will be never replaced by AI. Humans with AI will replace humans without AI. Humans will never be replaced by AI, but humans with AI will replace humans without AI. Mobile phone will never replace humans. Humans with mobile phone, but these happiness, all those things I don't know. But the drivers are not. You're not going back to your print phone. Use it carefully, but you should be careful. There are voice hallucination, bias. There is something called AI poisoning. You will get wrong data. You will be wrong. Use it. Now, why I told this, you should not use for routine things. When you want to clarify, it makes more efficient instead of just do the search. As we read here, slowly in between, you put you have got a ChatGPT app. Okay. Do you know there are two things? Ordinary ChatGPT, you are putting yes and it's ChatGPT Scholar. Okay. Each one of the merits. Scholar is for your team. Go to ChatGPT, put hemoglobin A1C variants, HbA1C variants. Okay. These are actually. Okay. You are not getting bored now. So tell me. Then I will leave that. Okay. We are coming to the HbA1C variants. What Madam was trying to explain to you is fasting sugar okay, sugar okay. The estimated average glucose A1C should have been around less than 7. There is a rough proportion. And this A1C of 10 and above is one reading or last 2-3 years reading.
last 1 year? At least.
Before that, probably.
Before the COVID was higher, sir, around 8, 9. But now it has come 10.8. Almost
Okay.
like-
Then what madam was trying to tell you, there is something called A1C is supposed to be based on mean glucose over the last 3 months. But there are other factors which will influence. One madam told about iron deficiency, anemia, all those things which affect hemoglobin, turnover, etc. But and hemoglobin of these thalassemia, sickle cell anemia, the measurement, and don't get A1C in some track labs. It should be by APLC. It should be from a good lab, otherwise you are wasting patients' money. There are variations in this. You can get falsely high A1C variant, falsely low A1C variant. Some drugs do. Where person is on level C drug backbone, A1C below sugar will be high. Here, measured sugar is normal, but A1C is high. It may be a false A1C variant. I don't think she has anemia and all. If it is consistently, always there is a discordance between your true hemoglobin electrophoresis. You may you have heard of thalassemia. You might hemoglobin is slightly low, so you need catch this lady, get your grandma to meet her, and she will make the. Okay, one more thing. If somebody's A1C is variant, normally you say keep around 6.57. The variant you have 8 is the normal part, or 9 is the normal. So you can't put them. Any other question. Did you get the A1C variant? Okay, madam told us hemoglobin variant that interfere with the. Okay, there are two things. One is a laboratory error or laboratory variation, measurement variation, like this hemoglobin of this. Another is the lab analysis is good biological variation, like anemia, iron deficiency, etc. Hemoglobin variant that interfere with HbA1c value, certain hemoglobinopathies, thalassemia, RBC lifespan, like you mentioned, hemoglobin structure, lab assay accuracy, falsely low A1C. Your mother's maybe not high A1C. Hemolytic anemia, recent red loss, pregnancy, chronic kidney disease, falsely high A1C, has made report iron deficiency anemia, splenectomy, chronic alcoholism. Okay. Anybody has heard of fructosamine? Don't worry about it. It's another marker. But that's you might not have seen, you saw the one. The most advanced, last time we demonstrated, is called artificial pancreas or automated insulin delivery like pacemaker. You have the CGM here, metal glucose. Okay. You know how beta cell works? How? Okay, you have your breakers. Put inside glucose phantom, goes to the pancreas beta cells, enter the cells, glucose transporter, inside there is glucokinase, it senses. If she has taken 2 vadas, it will have gone up, 1 vada low, it goes back to it. Proportionately, it returns the insulin release to glucose sensor, beta cell brain, think what we ate, how much is the glucose going like this, proportionately. 3 parts. Glucose sensor, beta cell brain, and a packed insulin. So same artificially glucose setting type 1, the pancreas beta cells are brain. Patch glucose sensor. The beta cell brain is in your mobile phone. The glucose levels go. It also tells you to 3 hours tells the whatever it is. Then it will tell the pump, talk to the pump to deliver. So pancreas is the BGD units. It's called automated insulin. Pancreas. If you can tell, it is, we started the first pump in India in 2002. With the first automated pancreas in 2020, beginning of COVID. The commercial one cost 6 lakhs in initial investment and 30,000-40,000 rupees a month. And that applies. There's something called DIY, do it yourself. So you can reduce the cost. You can come. Last time we were able to demonstrate 2 kids had come. One day hope it will happen. Atmanirbhar. Any questions before we go to part 2, please?
One is
if the experience is around 5.8 or 5.9 for the whole 1 year, like every 3 months we check and it will be around 5.8 or 5.9. So is that like something or not? Like it's very borderline. It's not like diabetes also pre-diabetes also. So should we start? I have seen many people with those conditions. Like, for the past 2 years, like every 3 months they check, it will be around 5.8 or 5.9. That is not. The range is your pre-diabetic range.
Should we start?
If they are obese and if they have any family history or in such conditions, yes, you can start.
You saw the slide there. Even the FDA has not approved any medicine for pre-diabetes. But it can
Prevention.
no medicine. That in a pre-diabetic stage, it told them. There is nothing
Or
possible
prevent, yeah.
to prevent progression to height.
Yeah.
But there is no medicine, but it is widely used. It has much more benefits than just reducing the sugar. And I could use Dharmaharindra or Rasana.
People with other conditions like the EF condition or the knee condition, in them should be tell Ayurvedic diabetes. In them, what can we do like, other than this walking? They can't do this walking, right? Like the EF is around 35 to 45 or the knee condition. What can be done? See, there are sitting exercises. They teach you by sitting on the chair how you can, lift the leg, do sidewise. Those things, little bit of flexibility, those things we can do. And for them, the diet cannot become more important because they are not able to burn the calories in any other way. But yes, they can walk inside the house, inside in the balcony. They can do 15 minutes after breakfast, lunch, and dinner. They can walk for 10 minutes, whatever possible. Within their house also they can walk. These small things you can make them.
Who told you the ejection fraction is very good?
Right.
They can't exercise for. They can't run, but they can use
No, but it's okay. It's not always this work. You can walk in your own pace, even that is good.
compensate to tell you they can walk with their mentally. Any question before we go to part?
So we can take some questions.
Okay,
We
okay.
discuss in the discussion session. Please queue your questions for that.
My dear friend, take up from myself. I'm a bit serious. He's very jovial. He's got a lot of jokes. Keep you humorous. But I also, for him, I have a bit few things. And I was talking. Recently, I met the people from Sri Ayurveda is here. I met a couple of students at by name Mr. Chuck. Anybody know? He's in Sri Ayurveda. And because I want to learn from him how to be not to be serious. So the boy came to me for some discussion. I was talking, I was taking the family history. But you know what was his brother's name? Hey, you know that boy? I don't know that boy. His brother was Srisha. This boy said, and I said, is he going to become no, he's also going to be a physician only. Then I got worried. I told him, what is the name of your father? You know him? What is your father? No, grandfather. That's right. Okay. The father's name is not. And what's your father's name? He said, no father, grandfather is the he said, no, Ayurvedic family. Okay. And I was in two small things. I was in a meeting in CMW. I met an endocrine surgeon from US. His name was Electron Haberview. He's a very serious. His name was his name. He said, black man, highly accomplished surgeon. We were with him 3 days, and last day they were asking question and answer session. He was so nice. I stood, everybody was asking a surgical medical question. He said, Mr. Haberview, what is the name of? I didn't ask of your brother and sister. You know what he told? Proton Haberview. My father was and I could be the school. And one last thing, in that another meeting, I met a guy called Sunil Poliwal. You can Google. He's an Indian Harvard boy settled in US. He's an MD, physician scientist. I met him. He gave me the visiting card. How do you spell Sunil? No, he's visiting card at SUNE. And many people do it for numerology. One brought me. What is this SUNE? Can anybody guess? I'll really give you a prize. Okay. Okay. It's difficult to guess. He was born on the day Neil Armstrong landed. His father was the NASA scientist in US, the father. So the day the baby was born, he named it as Neil Armstrong. And one more thing, small thing for him. You talked about metformin, they talked about obesity. Let's say we are working with ISC. There was a very beautiful lecture with Madam Pulkam by a professor called Sri Kumar Nayak. He's an Indian physician scientist, settled in Mayo, is one of the top researchers. You are talking about obesity. His work is on the effect of obesity on the brain. Endocrinologist. I will just summarize his lecture, one line. Madam talked about obesity, etc. in everything. If you are lazy, if you eat bad foods and put on fat, you lose your muscle. What is that called as? Sarcopenia. Listen to me carefully. I didn't know the next part. His conclusion, it's a very beautiful lecture, animal studies, human studies. If you are lazy, if you eat bad food, if you put on fat, you lose your muscle, sarcopenia, and you lose what else? You lose your brain. It causes cognitive dysfunction and brain atrophy, and even more human studies. Amazing work on pre-diabetes. Don't think pre-diabetes is borderline. We can damage your doctor, you too. Insulin resistance is as bad as the natural cause. He took people with randomized study, pre-diabetes, they will see 5.7 to 6 point something. Half of them, placebo, half of them metformin. The metformin was able to protect against brain loss. They did fMRI. Yeah, if you don't take metformin, your brain size decreases, your hippocampus decreases, function decreases. So if you put on fat, you lose muscle, you lose your brain. Okay, got this. And metformin does
Let me take you through this important but busy slide on the profiles of various anti-hyperglycemic medications. On the horizontal line is listed the various medications, beginning with metformin, GLP-1 receptor agonist, dual GLP-1 receptor agonist, SGLT2I, TZD, insulin, basal and basal bolus, DPP4 inhibitors, sulfonylureas, glinides, alpha glucosidase inhibitors, the rarely used drugs, polycetanol, bromocriptine, which we use quite extensively, pramlintide. On the vertical axis are the various properties of each of these compounds. Blue indicating possible benefit, orange indicating use with caution, red indicating likelihood of adverse events, gray indicating neutral, not studied or insufficient evidence. We all like drugs which maximum benefits. We want more blue and least red. The various beneficial effects or the pleiotropic effects and the challenges are listed vertically. Efficacy for glucose lowering from metformin to insulin to SU. Benefit in atherosclerotic cardiovascular disease, major adverse cardiovascular events, congestive failure and stroke. The beneficial medications for this ASCVD include GLP-1RA, dual agonist, SGLT. Then CKD, the benefits are from SGLT2 and GLP-1RA. Hypoglycemia, metformin, GLP-1RA, dual agonist, SGLT2 are all, and DP4I are all neutral. Weight, benefit in terms of the weight. Metformin can cause slight loss, whereas GLP-1 dual agonist SGLT2I cause much significant loss. The highest benefit is with GLP-1RA and dual critics. Benefit for NAFLD or GLP-1RA dual agonist SGLT2I. And as far as cost is concerned, the cheapest are metformin and sulfonylureas, and now even DPP4I. So match the medication to possible benefits and least adverse effects. This is a similar table about the profiles of the weight loss medications I mentioned earlier. The only two drugs which have salutary effects are semaglutide, liraglutide, and the newer tirzepatide, and they can promote up to 20% weight loss. And the obviously the cost is a limitation in our country. Section 10, cardiovascular disease and risk management. Shown in this slide is a simplified algorithm from ADA regarding hypertension management. There are two arms for this algorithm. First one, if the initial blood pressure is less than 150/90, start with one agent. If the initial blood pressure is greater than 150/90, start with two agents, of course, with lifestyle management. If there is albuminuria or coronary artery disease, start angiotensin converting enzyme inhibitor or angiotensin receptor blocker. In this arm, with more severe hypertension, start with ACI or ARB, along with calcium channel blocker CCB or diuretic. Assess blood pressure control and adverse effects. Treatment tolerated and target achieved, continue therapy. Not meeting target, add agent from a complementary drug class, that is the third agent. Adverse effects, consider change to alternative medication. Again, continue the process, assess blood pressure control and adverse effects. Not meeting the target or adverse effects, using a drug from each of the three classes. Then it becomes what is known as resistant hypertension. One of the most important causes for resistant hypertension beyond chronic kidney disease is an entity called primary aldosteronism, which is hardly diagnosed in our country. Obstructive sleep apnea is also one of the causes for resistant hypertension, and all patients with resistant hypertension taking 3 or more drugs, including a diabetic, need special investigation. Finally, both in cases of primary aldosteronism and in other situations, primary aldosteronism, the specific drug of choice is a mineralocorticoid receptor antagonist called MRA. There are a few other classes of drugs which should be used in resistant hypertension. This slide illustrates the current ADA recommendations for screening for asymptomatic cardiovascular disease. Who to screen? For coronary artery disease, routine screening is not recommended for asymptomatic individuals. If atypical cardiac symptoms, signs or symptoms of associated vascular disease or electrocardiogram abnormalities are present, screen using routine methods. Now, heart failure. Screen all adults with diabetes, which increases the risk for asymptomatic stage B or symptomatic stage C heart failure. Measurement of B-type natriuretic peptide, BNP, or N-terminal proBNP, NT-proBNP, echocardiography is recommended for those with abnormal BNP values. NT-proBNP measurement is increasingly being used in our country. Peripheral artery disease. Screen individuals with diabetes at age greater than 50 years, any microvascular disease, foot complications, or end organ damage from diabetes. Also consider screening anyone with diabetes duration greater than 10 years. The screening simple test is called ankle brachial index testing, which can be done in any clinic. This slide illustrates the treatment of stage B or asymptomatic heart failure in people with diabetes. To reduce the risk of progression to symptomatic stage C heart failure, treatment with and ACI or ERB and beta blocker is recommended. If high risk for or established CVD, you can add an SGLT2. If their patient has diabetic kidney disease, another MRA or phenylenone is being recommended. Now, little information about dyslipidemia. How often should we check lipids? For people with prediabetes or diabetes not on lipid lowering therapy, check at diagnosis and at least annually thereafter. Check lipids at initiation of lipid lowering therapy, 4 to 12 weeks after initiation or dose changes, and annually thereafter. Now, statin therapy is classified into high intensity statin therapy, which can lower LDL cholesterol by greater than 50%, and moderate intensity statin therapy, which lowers LDL cholesterol by 30 to 49%. The standard drugs are atorvastatin and rosuvastatin, 80 milligram and 40 milligram for high intensity, and 20 milligram and 10 milligram for moderate intensity. Now, information on the algorithm for lipid management for primary prevention of atherosclerotic cardiovascular disease events in people with diabetes. It also depends upon the age group. Lifestyle therapy is common to all. In people 20 to 39 years of age with diabetes, consider statin therapy. There are additional ASCVD risk factors. In people 40 to 75 years of age, use moderate intensity statin in those without ASCVD, high intensity statin in those with greater than or equal to 1 ASCVD risk factor, targeting an LDL cholesterol of less than 70 milligram per deciliter. Use bempedoic acid for those who are statin intolerant. In people who are on high intensity statin, it may be ezetimibe or PCSK9 inhibitor, maximum tolerated statin therapy. In people greater than 75 years of age, continue current statin therapy or consider initiating a moderate intensity statin after weighing risks and benefits. So the most aggressive therapy is in that group of people in the age group of 40 to 75 years who have significant lifespan ahead of them. This algorithm is for lipid management for secondary prevention of ASCVD events in people with diabetes of all ages. As you know, secondary prevention means the patient already had a cardiovascular event like MI, angioplasty, bypass, stroke, peripheral vascular disease, etc. The previous slide was for primary prevention. For secondary prevention, on top of lifestyle therapy, the uniform recommendation for all ages is high intensity therapy to reduce LDL cholesterol by greater than 50% from baseline to a target less than 55 milligram per deciliter, not 70. We target even 25 to 35 based on available literature data. Add ezetimibe or a PCSK9 inhibitor if LDL cholesterol goals are not met on maximum tolerated statin therapy. Use an alternative lipid lowering agent for those who are statin intolerant, which includes PCSK9 inhibitor, which is a monoclonal antibody, bempedoic acid, and PCSK9 inhibitor with the new medicine called inclisiran, which is a small interfering RNA. Section 11, chronic kidney disease and risk management. Again, few fundamentals which all of you are aware of. Screening for chronic kidney disease. Who? Everyone with type 2 diabetes, everyone with type 1 diabetes for greater than or equal to 5 years. How to screen? Urinary albumin to creatinine ratio, estimated glomerular filtration rate. How often? Annually. Monitoring established CKD. Urinary albumin creatinine ratio and EGFR using the CKD epidemiology collaboration, CKD EPI or refit equation, which eliminates race as a variable for all individuals. 1 to 4 times per year, depending on the stage of the chronic kidney disease. Again, all of you are familiar with the current classification of CKD. CKD is classified based primarily on two biomarkers, GFR, the GFR staging, and albuminuria, the albuminuria grades. The GFR staging is from G1 to G5. G1, GFR above 90, G2, 60 to 89, G3A, 45 to 59, G3B, 30 to 44, G4, 15 to 29, G5, the so-called kidney failure or end-stage renal disease with GFR less than 15. Regarding the albuminuria grade, it is A1, A2, A3. A1 is urinary albumin creatinine ratio less than 30. A2 is ACR 30 to 299. A3 is ACR greater than 300. So the healthy shown in green is GFR greater than 90 and ACR less than 30. The worst situation is GFR less than 50 and ACR greater than 300 shown in red. However, the progression is not perfectly according to both of them. There are different variants. One variant is non-proteinuria chronic kidney disease, where you may not have much albuminuria, but the GFR may be low. On the other hand, you can have higher albuminuria within normal EGFR. So there is heterogeneity and slight pathogenetic differences. So the cause of CKD also becomes important. One simple, fundamental and crucial question. Why manage CKD? Is it only for the kidney? No. Management of CKD decreases risk of progression of CKD as well as reduces the cardiovascular risk. It is twin benefit. Shown here is a very good holistic approach to improving outcomes in people with diabetes and CKD. Again, the initial emphasis is on lifestyle, healthy diet, physical activity, smoking cessation, and weight management. The first line drug therapy after metformin, if the EGFR is greater than 30, is SGLT2I. Initiate if EGFR greater than 20, continue until dialysis or transplant. Next, ROS inhibitor, renin-angiotensin system inhibitor, that is ACI or ARB, at maximum tolerated dose if hypertensive. Regular assessment of glycemia, albuminuria, blood pressure, CVD risk and lipids. Then additional risk-based therapy. One can add GLP-1RA if needed to achieve individualized glycemic target. Other glucose-lowering drugs if needed to achieve individualized glycemic target, optimal HbA1c. Then on top of the RAS inhibitor, you can add non-steroidal MRA like finerenone. ACR is greater than 30 and normal potassium. Can add dihydropyridine CCD and or diuretic if needed to achieve individualized BP target, followed by MRA or resistant hypertension if GGFR is greater than 45. Dyslipidemia management is also crucial with moderate and high intensity statin, followed by antiplatelet agent for clinical ASCVD. And as I mentioned, you can add ezetimibe, PCSK9 inhibitor, and there is also a role for the derivatives of fish oil, here known as icosapent ethyl, based on ASCVD risk and lipids. Few important clinical tips in relation to diabetes and CKD. Periodically check serum creatinine and potassium levels when ACE inhibitor, angiotensin receptor blocker ARB, or non-steroidal mineralocorticoid receptor agonist MRA is used. Do not discontinue ACI or ARB therapy for increases less than 30% in serum creatinine in the absence of volume depletion. So when you start ACI or ARB, occasionally serum creatinine increases. If the increase is less than 30%, do not worry. Aim for urinary albumin reduction greater than 30% in people with CKD and urinary albumin in grade 3, that is more than 300 milligram per gram, to slow CKD progression. Reduction of albuminuria is also. Section 12, retinopathy, neuropathy, and foot care. Regarding diabetic retinopathy, optimizing the management of glycemia, blood pressure, and lipids has been documented to reduce or slow the progression of microvascular complications of diabetes, including retinopathy. Screening for diabetic retinopathy. Recommended diabetic retinopathy screenings can allow for timely treatment to prevent or even reverse vision loss. How? Dilated comprehensive eye examination and retinal photography. When? For people with type 1 diabetes, within 5 years after the onset of diabetes. Immediately now, for people with type 2 diabetes, beginning at the time of diabetes diagnosis itself. Follow eye exam schedule at least annually for people with any level of retinopathy. Every 1 to 2 years for those with no retinopathy, or for one or more annual exams and well-managed glycemia. More frequently for those with progressing or sight-threatening retinopathy. Treatment of diabetic retinopathy. Treatment. Promptly refer to an ophthalmologist who is knowledgeable and experienced in managing diabetes retinopathy. Any individual with one, any level of diabetes macular edema. Two, moderate or worse non-proliferative diabetic retinopathy, which is a precursor of proliferative diabetic retinopathy. Three, any proliferative diabetic retinopathy. Now, similar information on neuropathy. Neuropathy screening. All people with diabetes should be assessed for diabetic peripheral neuropathy starting at the diagnosis of type 2 diabetes, 5 years after the diagnosis of type 1 diabetes, at least annually thereafter. Symptoms and signs of autonomic neuropathy should be assessed starting at the diagnosis of type 2 diabetes, 5 years after the diagnosis of type 1 diabetes, at least annually thereafter, and also people with evidence of microvascular complications, particularly kidney disease and peripheral neuropathy, who are more prone to autonomic neuropathy. Treatment of neuropathy remains a challenge. There are different types of neuropathy, and the treatment has to be individualized. There can be painful neuropathies, there can be painless neuropathy. Number two, there can be mononeuropathies or polyneuropathies. Various drugs may reduce the pain from diabetic peripheral neuropathy, and both drug and non-drug strategies may ease symptoms of peripheral neuropathy and autonomic neuropathy. The safest and most evidence-based pharmacological options for diabetic peripheral neuropathy include GABA-pentinoids, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressant like the old simple amitriptyline, and sodium channel blockers. Refer to a neurologist or pain specialist when pain control is not achieved within the scope of practice of the treating clinician. The importance of regular foot care in a patient with diabetes can never be overemphasized. Simple but life-saving and life-saving. I still remember a golden burst of Dr. Sharad Pendse of Nagpur, who is one of the pioneers of diabetes foot care, a Swamiji for diabetes foot care of our country. He made a profound statement that when a diabetic patient enters the clinic, the doctor should not shake his hands. The doctor should bend down and touch the feet of the patient. That is the importance which the doctor and the patient has to give for limb salvage and good foot care. Initial treatment recommendations should include daily foot inspection by the patient, use of moisturizers for dry scaly skin, and avoidance of self-care of ingrown nails and calluses, well-fitted athletic or walking shoes with customized pressure relieving orthosis for people with increased plantar pressures, example with plantar calluses and the condition known as short cord split or diabetic neuroarthropathy. Again, risk stratification and screening frequency for foot care. There are 4 categories. Ulcer risk from very low to high. Category 0, diagnosed when there is no loss and no PAD. Loss means loss of protective sensation identified by the monofilament, no peripheral arterial disease by symptomatology, palpation of the pedal pulses, and ankle platelet index. Examination frequency annually. If there is loss of PAD, every 6 to 12 months. If there is both loss of protective sensation and of peripheral arterial disease or loss PAD with a foot deformity, then more frequently every 3 to 6 months. In case there is a loss or PAD, and one or more of the following: history of foot ulcer, amputation, minor or major, end-stage renal disease, you will have to examine the foot every visit to the clinic. Now, let me share a few thoughts on Ayurveda and diabetes therapy. Okay. Bridging ancient wisdom and modern science. Each of the pathogenetic loci provide an opportunity for therapeutic intervention. In terms of beta cells, increased insulin secretion is provided by sulfonylureas, meglitinides, and incretins. Glucagon secretion is reduced by incretins. Incretins and amylin play a role in appetite control. Bromocriptine decreases neurotransmitter dysfunction. SGLT2 inhibitors decrease glucose reabsorption from the kidneys. Metformins increase glucose uptake and utilization. Lipotoxicity decreased with thiazolidinediones. Hepatic glucose output is decreased with metformin, again at the level of the gastrointestinal tract. Incretins, alpha glucosidase inhibitors, amylin, and bile acid sequestrants play a role. The same will be true for Ayurveda-based diabetes medications with multiple loci and multiple mechanisms of action. This slide summarizes the various potential mechanisms of action of Ayurvedic bioactive molecules in diabetes therapy. They include pancreatic and extrapancreatic effects. The pancreatic effects include stimulation of the beta cells, perhaps regeneration of the beta cells, and inhibition of the alpha cells. The extrapancreatic effects of the Ayurvedic medications could include improving insulin sensitivity at the post-receptor and receptor level, delaying gastric emptying, slowing carbohydrate reabsorption. They could also cause gluconeogenesis decrease through inhibition of glucose 6-phosphate and phosphatase and fructose 1,6 biphosphatase. They could increase glucose oxidation through stimulation of glucose 6-phosphatase, dehydrogenase pentose phosphate pathway. Glycogenesis can increase. There can be glucose transport inhibition, alpha amylase inhibition, and alpha glucosidase inhibition. Our collective interdisciplinary and translational scientific dream is: can we identify and implement many more metformins, gliflozins, and more digitalized vinca taxons and the likes from plant and other natural products? In a philosophical way, I can assure you that Lord Almighty was not so stupid to discover or to give mankind with only $2 billion medicines, that is metformins from French lilac and gliflozin from the apple bark. It is very obvious that there are thousands and millions of plants who have medicinal properties which have to be identified and utilized to improve human health. Natural product pharmacotherapy, phytotherapy, and phytopharmacotherapy will be an important paradigm for all of us to pursue in the coming decades and centuries. And our motherland, Bharat, has to take a lead, and the journey has just begun. The low success rate of discovery thus requires a paradigm shift for innovative drug development strategies. Innovative drug discovery starts by deriving inspiration from natural products, from learning from nature for effective treatment of disease conditions. The relevance of natural products in providing innovative drugs to find solutions to communicable and non-communicable diseases cannot be overemphasized. Besides physical health of human beings, spiritual health needs equal attention. As mentioned by illustrious speakers on day one, science and spirituality needs integration in the field of healthcare and every other human endeavor. Health, happiness, peace, and prosperity, infinite and eternal, shall remain the dream for the mankind. One world, one family, one future. Thank you all. God bless you.
Thank you, sir, and thank you, Kavita madam, for providing us an informative and insightful session. So now we will take a tea break. Please reassemble after 5 minutes without much delay. We will be continuing the next session.
Pen drive.
ನಲವತ್ತು ಮಾಡಿದ್ರು so far. ನಲವತ್ತು ಸೇವ್ ಮಾಡಿದ್ರಿ ಸರ್, ನೀವು 40 ಸೇವ್ ಮಾಡಿ ಅಟ್ಲೀಸ್ಟ್ 6 ತಿಂಗಳು ಜಾಸ್ತಿ ಬೇಕು ಸರ್. ಅದು ಬೇಕಾ ಅನಲೈಸ್ ಮಾಡ್ತೀವಿ, ಫೈನಲ್ ರಿಪೋರ್ಟ್ ಮಾಡ್ತೀವಿ.
ಇವತ್ತು ನಮ್ಮ IC ಮೀಟಿಂಗ್ ಆಲ್ರೆಡಿ
ESME ನೀವು ತಗೋತೀರಾ ಸರ್, ಒಂದು ಮೇಲ್ ಹಾಕಿ.
She's finishing her last visiting patient for 20.
ಸರ್ ಅಲ್ಲಿ ಆಗಿದ್ಯಾ? ಆಗಿದ್ಯಾ? ಸುಮ್ಮನೆ ಚಾನಲ್ ಪರಾನ ಇದಕ್ಕೆ ನನಗೆ
ಅಲ್ಲ ಅವ್ರು ಕ್ಯಾಟರಿಂಗ್ ಪೀಪಲ್
ನಾನು
Yeah, this slide should give you
Go do all this. So I will tell namaste and I will see you there.
slide should give you
You can ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಈ ಕಡೆ ಅವ್ರದ್ದು ಕ್ವಶನ್ಸ್ ನಾವು ತಗೊಂಡಿಲ್ಲ. They want make you can just write to us.
Thank you so much.
Thank you, madam.
Now, really good. They can upload the lecture and send it to students.
Students, you
Website will have to share ಮಾಡಿ.